Hello, Web Shadowers. Thank you all for attending our session this afternoon. Today, we have the pleasure of hosting Dr. Chandrasekaran, who will be teaching us about pulmonary critical care. And as always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With that being said, Dr. Chandrasekaran, you may start when you're ready.
All right. Hi, everyone. Thanks for having me. My name is Neena Chandrasekaran. You guys did an awesome job of pronouncing my last name. I usually just have my patients call me Dr. C. So today I'm going to be talking about pulmonary critical care and going over a couple of interesting cases. For those of you who saw me back in fall, hi again. And this PowerPoint actually does still say fall. So just to begin, a little bit about my specialty. It's board certified in two different specialties, I guess. One is pulmonary, which is the study of lung pathology, and that has to do with any type of lung diseases, whether it's clots in the lungs, whether it's fibrosis, whether it's fluid in the lungs, shortness of breath, asthma, COPD. It's a huge spectrum, anything pretty much with the lungs. That's what we are responsible, or that's our specialty. Then there's also critical care, which kind of goes hand in hand with pulmonary and also does go hand in hand with a few other specialties. This is a specialty where we deal with the sickest of the sick. If a patient's on their deathbed, critically ill, on the ventilator, on some type of life support, or they need very close monitoring, then they're usually in the ICU. The ICU, or the intensive care unit, is the sickest of the sick in terms of hospital settings, or where pretty much one can be. So a little bit about me. I did my undergrad in Florida, UCF. I did my residency, I did my medical school at AUA, American University of Antigua, which is a Caribbean school. The way that school has it is you do 2 years on the island for the basic sciences. And then after the years on the island, you go to you do your rotations kind of wherever you want, but it depends where the school is affiliated with, what hospitals they are. So my specific school that I went to, AUA, did have an affiliation with FIU, Florida International University in Miami, which helps since I'm from there. So I was able to do my whole third year in FIU. And then I did my fourth year rotations, half of them in Orlando Regional, a few of them along with the rest of them in New York. So it was kind of cool to see the varying demographic ways that medicine plays a role in, I guess, the different practices between the Northeast and the South. Oh, and then I did my internal medicine residency in University of Pittsburgh Medical Center. So I'm board certified in internal medicine, and now I am doing my fellowship, which is specialty in pulmonary critical care in Detroit. So let's get started with the case. This case is a real case. Some of the identifiers were changed for HIPAA privacy, but this is an example of something that we did see, if that makes sense. So we have a 25-year-old male. Oh, sorry, there's a lot of abbreviations. That's kind of just how we type in the medical field. 25-year-old male with a past medical history of diabetes mellitus, or DM, comes into the ED for abdominal pain and shortness of breath. He reports the pain has been going on all day, past 5 to 6 hours, more specifically. He states he has never had any pain like this before and endorses retching and nausea. He states he did vomit a couple of times as well. For shortness of breath, he says it just feels like he can't catch his breath when he tries to take in a deep breath. Endorses some mild chest pain, no cough, no fevers, no sputum production or mucus production. So when we're interviewing a patient, any patient in the ED clinic, any type of urgent care, any type of setting, we usually try to get an HPI from them. So we ask them what's been going on, ask them questions about their chief complaint. For this gentleman, it was abdominal pain and shortness of breath. Other important things to always ask are past medical history. And this patient, who's young, only 25, says his past medical history was just diabetes mellitus. Past surgical history. It's always important to ask past surgical history. For this patient, he just says appendectomy. But past surgical history can sometimes tie into a chief complaint. For example, if somebody just had a thyroid removed and they're coming in with weakness and feeling fatigued, then maybe that has to do with the fact that they just had their thyroid removed. So it's always important to ask that past surgical. Past family history. This is also important too, because if you're suspecting maybe a cancer in somebody and they have a strong predisposition with their family, then that can also kind of clue you in. And also different types of syndromes can be familial associated. So for this person, he says his past his past family history, his mother has diabetes, just like him. We all do know that diabetes does have a familial predominance. If someone in your family has a disposition, then one might be more inclined to get diabetes later on in life. And then he says father with some type of lung disease. Not too specific on details of both of these. Social history and young patients especially, this is very huge, but this is also very important on honestly any patient. Even if it's like a 90-year-old patient, it's really important to know what their functional status is, what their social history is, because this ties into so many different conditions. So this patient specifically says he uses tobacco use daily. He has smoked since he was 18 years old, 1 pack per day. 25, he's 25 years old. So you do 25 minus 18, you get the pack year history. He has no other illicit drugs and drinks occasionally. So normally for social histories, things that we do ask are any types of substances that are being used, whether it's heroin, cocaine, alcohol, marijuana, cigarettes, vaping. Vaping is big now. About 2 or 3 years ago, we as the pulmonary have incorporated that into our social history, specifically asking not only about marijuana, smoking, heroin, cocaine, but also specifically about vaping. Other things that are important to use social history when you do ask these questions, you ask for how long, how many times a day, have you ever tried to quit? Alcohol is big too. And to ask specifically how many years have you been drinking for? Have you ever tried to quit? Other things that are important for social history would be any type of jobs that they do. Do they live at home? Do they have kids? Do they have a significant other? Do they have pets? Things like these are important just to kind of get a general picture of who the person is. If they're older and like their 80s, 70s, sometimes we'll ask, do you drive? What type of activities of daily living do you do by yourself? Can you cook? Can you bathe yourself? Can you clean the house? And these kind of have more of an importance to play in terms of different medications or treatments that we would put somebody who might have a more serious condition if they're older on. All right, so just going back to our case here, we have a 25-year-old gentleman with a past history of diabetes mellitus who comes into the ED for abdominal pain and shortness of breath. Is there anything else that you all would like to know? You can just put it in the comment section, and I will take a look at it. I will just give about a couple, I'll just give like a couple minutes for the sake of time. Also, what's important to know about this guy that I would personally ask would be, actually any mitigating factors. I think that's a great question. That is something that I would ask too. What's kind of bringing this on? Is it like a smell? Because if this patient is getting nauseous from a smell, sometimes that can make you think that there's a seizure disorder history. There's something called triggers or AURAs, AURA, with seizures. And if somebody smells something, then that could bring on a seizure. So that's a great question. Any mental health history? That's also a great question. Patient didn't specify any mental health history, but that's also something very important to specifically ask as well. Current meds, always a good question. Maybe they just were put on something that's making them vomit more. So yeah, for this patient, current medications, he just says insulin. So he is on insulin for his diabetes, but other than that, he is on no medications. Hematemesis, that's a great question. So hematemesis is vomiting blood. That is one question I would ask. I would say, okay, so I would ask the patient, I would say, okay, so you're vomiting. You vomited a couple of times and you're retching and nauseous. How is the vomit? Is it bloody? Is it brown? Is it green? Does it happen all the time? Is it bilious? These can kind of help to see if it's like an ulcer in his stomach. If he popped a vessel for the blood, does he have a blood clot, which is why he could be bleeding blood? So that's definitely a good question. Does he exercise? He says that he exercises sometimes. Okay, so those are all great questions, and those would be some other questions that I would ask. All right. So now kind of going into the differentials, whenever we have a patient, we have a chief complaint, we've interviewed them, we've gone through our questions, things that are going through my mind, I'm thinking about what can this be? And this is important for our workup. So in my head, I'm like, differentials could be pneumonia. Very common presentation, a patient with shortness of breath and abdominal pain. Sometimes patients, when they have pneumonia, they have a lot of sputum and they just keep swallowing it over and over and over. And because they keep swallowing it over and over, it goes into their stomach. That makes them nauseous. So pneumonia is on my head. I'm thinking, okay, I have to get some type of imaging of his lungs to check if he has pneumonia. And also patients can be more possible or predisposed to getting pneumonia who have underlying conditions. This patient has diabetes. This patient is vomiting. People sometimes when they vomit, they can aspirate on their own vomit or aspirate on something that they're eating. And by aspirating, that means when we eat, the food normally goes from our mouth into our esophagus, into our stomach. But sometimes if somebody is vomiting, it can go the wrong way or the wrong pipe, as we call it. So from the mouth, it'll go straight through the trachea and into the lungs. So that can cause what we call aspiration pneumonia. It's another type of pneumonia due to food going down the wrong pipe or aspirating. So that's on my head as differential. Other things would be SBO. That's a small bowel obstruction, and that can happen from just not pooping. Sometimes people can get constipated and just not use the bathroom. And this is actually pretty big and kind of goes hand in hand with gastric emptying. And this would be this can be due to diabetes. Some patients that have diabetes, they have difficulties emptying their stomach. And this has to do with the fact that diabetes is a disease where you have a lot of glucose in your blood, and glucose sugar, it attacks nerves. So it can attack nerves anywhere. It can attack nerves in the colon, and when it attacks nerves in the colon and the mesenteric system, or basically our stomach, it can kind of stop the nerves from pushing the food forward. And that's what we call gastric emptying or delayed gastric emptying. So I'm thinking, okay, maybe he has a problem with, because of diabetes, he's having trouble moving the food forward. Ulcer is always on the list. Patients sometimes take a lot of NSAIDs or ibuprofen, things that can harm the stomach, and that's always on the list of differentials in a young person, even an elderly person, actually, especially an elderly person who's coming in with abdominal pain, nausea. That's in my head as well. DKA is diabetic ketoacidosis. This is seen in patients who are on insulin, who have diabetes, and who are sometimes uncontrolled with their treatment, meaning they're not compliant with their medication. Maybe they have an infection that triggers them to go into diabetic ketoacidosis. It's basically a syndrome where there's too much glucose in the body, and that's causing the body to kind of shut down on itself by producing a lot of acid and a lot of ketones. So the body is trying to get rid of the glucose, but and the cells are not able to use the glucose. And so when the cells aren't able to use the glucose, they go through a different process. They are not able to go through glycolysis because all the glucose is kind of hanging out in the bloodstream. And because of that, they then produce ketones. So through some of you guys here, whoever is in biochem or going through the glycolysis cycle, just think about the Krebs cycle, but going to lactate instead of making aerobic ATP like we would want. So that's what we call diabetic ketoacidosis. Actually, we will be getting a little more into that a little later. So ileus is another type of small bowel obstruction. It's basically has to do with not emptying their stomach, meaning they are constipated, and now they have something completely blocking them from using the bathroom. So another thing on my mind would be a pleural effusion. That's just fluid in the lungs, and we will kind of get into that as well. So as I'm interviewing this guy, these are certain things that I'm thinking about, and the way that I would go about working them up for things like pneumonia, pleural effusions, ileus, SBO, ulcers, I would get imaging. Imaging would help take a look at the thorax and the abdomen and pelvis. So part of my workup would include a CT, abdomen, pelvis, and thorax. So this can kind of help me rule out some of these. I would do a CT thorax instead of a chest X-ray, because if I'm already going to send the patient for a CT, abdomen, pelvis, I might as well add on a thorax anyway. Then I would do labs. Labs would help see if there is a pneumonia, like if there's a white count or if there's something off on his labs that can maybe make me think something that I see on the labs, like he's losing hemoglobin, then maybe I'll think, okay, well, maybe he's not vomiting blood this time, but maybe he did vomit out blood and the hemoglobin has dropped. Also, labs would help in DKA, diabetic ketoacidosis, so we can get a good handle on the glucose, the kidney function. So labs are definitely important. Other things, EKG, trope, BNP. EKG is always something important to get, always, especially somebody who's short of breath. You just want to kind of make sure that they're not having heart problems. Even though this young guy who's only 25, it seems like, why would he have heart problems? You never know these days. So it's really important. Also, he has a predisposition of diabetes that can put someone more inclined to get heart problems later on. Troponin is a marker of, it's a cardiac enzyme that's released when patients do have problems with their heart or myocardial heart injury. Can also be released in other types of muscle injuries as well. And it can be elevated in patients that have kidney problems. BNP, this is a marker of heart problems as well. So in my head, I'm thinking, okay, these are differentials. Let's go through a workup. All right, so here's the CBC. So this is the blood count. You can see here the white count is 13, which is slightly higher. Normal is up to 11. Hemoglobin's 14. So for a male, it's probably like 1 point lower. We usually say 15 to 18. He's 14, not crazy. I'm not like, it's not raising a red flag in my head. Platelets are normal. The hemoglobin hematocrit normal. Platelets normal. White count slightly high. So I'm thinking, okay. This is the basic metabolic panel. So sodium is low, normally is 140. So this patient's at 130. Potassium is 5.0. Anytime you look at a potassium, you always check, you double check to make sure if it's hemolyzed or not. What hemolyzed mean is when somebody draws blood, sometimes the blood cells can break as they're drawing the blood. If the blood cells break, then that releases potassium artificially. So the potassium can sometimes be falsely elevated. But this patient, it wasn't falsely elevated. This patient had a normal an actual 5.0. That's on the higher side for a normal person. We say usually up to 4, we don't worry, but a potassium of 5, we're kind of suspicious, like why? Chloride 98, glucose 905. Now that's extremely elevated. We try to keep people below 100, so that's very high. So in my head, I'm thinking already, okay, this probably is DKA, hyperglycemia, because his glucose is 905. So then BUN creatinine, 32 over 1.4. This is unusual for a patient who is 25. We usually say their creatinine should be around, honestly, like 0.6 to 0.8. It usually depends on body mass. So in my head, I'm thinking, okay, this guy has kidney injury. It seems to be all related to hyperglycemia, and that's what's causing him to be dry and making the patient have a acute kidney injury, and the sodium is falsely low because of the glucose. So sometimes if your glucose is really high, you can get a falsely low sodium, and it has to do with the osmolality and osmolarity of the glucose and sodium itself. So the sodium is falsely low. So then we got an ABG in this patient, and it's 7.0. So ABG is an arterial blood gas, and what we sometimes get these in patients who do have high glucoses, or we're suspecting DKA, diabetic ketoacidosis, to check if they are if they're acidic or acidotic, if they're in an acidotic state at this time. So this patient's ABG was very low, 7.0, and the CO2 was 90. So I'm already thinking in my head, okay, this is acidosis. The criteria you need for DKA would be glucose greater than 250. We'll get into this in a little bit, but usually we look at 250, then we look and see if there's ketones in their body. As if for people who are doing biochemistry right now, you do know that the brain needs some type of fuel to survive. And when the body is going into starvation mode, into lactic acidosis, anaerobic metabolism, the brain uses ketones as a method of survival or some type of fuel. So if the body is going through anaerobic glycolysis because there's no glucose in the cells, and all the glucose just kind of staying in the blood, the cells can't uptake it because there's no insulin for the cells to uptake it or for the vital organs to uptake it, then the body will kind of break down muscles and take ketones and send that to the brain. So if the body has a lot of ketones, then that also kind of goes with diabetic ketoacidosis. And so that's what I'm thinking in this patient. So then we said we were going to get a CT chest, abdomen, and pelvis. So we get this CT abdomen, pelvis, and here going through this CT abdomen, pelvis here, it's not normal. Here's the heart, and then that's the esophagus. What's interesting in this specific patient is there's a effusion here, and it looks like it's what we call loculated. So loculated effusions, all this is supposed to be black, all of these here. The little white things can be vessels, but the way that this is kind of shaped in a very irregular shape and has different densities to it, meaning some parts of it are dark gray, some part of it is white. That means that it's loculated. And a loculated effusion just means that it's an organized collection. And that's a bad sign. That's a very poor sign. And that means that either the effusion has been going on for a while, could have first started out as a pneumonia, became a loculated effusion, or it means that it's a serious bacterial infection. So what's interesting here is there's gas tracing from the esophagus all the way down into this effusion. So on my mind, I'm thinking, that's crazy. This patient must have perfed his esophagus and got an effusion from that. What exactly does that mean? It means that the patient was retching so hard, just like vomiting so hard, that he blew a hole into his esophagus. And once it's all your mediastinum here, like your rib cage here is your rib cage here, and then your mediastinum. Your mediastinum has your heart, it has your lungs, it has your esophagus, and then your aorta. So he perfed his esophagus and then caused a fusion. And that's what we're seeing. So also what we did find in this guy is he had a pneumothorax. He had air in his lungs, which is crazy. That this poor, unfortunate person had both air in his lungs and a perfed esophagus. Questionable if the two processes were connected. It's possible, but he doesn't have any underlying lung diseases for it to possibly kind of be correlated together, which we'll talk about in a little bit, what it means to have an underlying lung disease to be correlated to a cause of air in the lungs. So we got a chest x-ray on this patient, and he had air in his lungs, whether it was from retching, whether it was from coughing so hard, or whether it was from spontaneous primary. That's what we're suspecting in this patient specifically, because he had no underlying lung diseases. So if somebody has underlying lung diseases like COPD, cystic fibrosis, some type of emphysema, asthma, even if they have cystic lung diseases, and then they do anything, trauma, play basketball, and then they get air in their lungs from that underlying lung disease, that's called secondary pneumothorax. But if it's primary spontaneous, and that's primary means no lung disease, and spontaneous is the way that the air in the lungs was occurred, whether it was traumatic or spontaneous, meaning just randomly. So this patient ended up having air in the lung. Now, when you look at a chest x-ray and you can see the air, what you see here is there's no lung markings here. Here you can see all these vessels going all the way out to the periphery, but on the right here, you see a distinguished, like a demarcated line here, and all of this is air. So this patient has a random pneumothorax. This unfortunate patient had a random pneumothorax, or air in the lungs, and he had a perfed esophagus with a loculated effusion. So what are our next steps? We have to put a chest tube for the pneumothorax because it's large enough. A chest tube is the treatment for a large amount of air. You can do a pigtail, but it depends. It kind of depends on the size of the pneumothorax, and it depends on the hemodynamic instability of the patient. So we have to treat the pneumothorax, place a chest tube, treatment for DKA. So like we spoke about, diabetic ketoacidosis is a very serious condition. It has to be treated emergently. It has to be treated emergently because a lot of glucose in the body, decreased sodium, there's a lot of osmolality fluctuations. You can get a lot of complications, and even herniate if it's not treated appropriately. Herniate means your brain can go down into your brainstem and you can die almost from it. And also patients become very acidotic, and in acidic states, your heart can stop essentially, because you need a balance in your body to be maintained. And if you're in a very acidic state, your kidneys will essentially stop compensating, and you can go into an arrhythmia that can essentially kill you. So the CT abdomen pelvis, like we said, had perforation and the pleural effusion. And then the next step was consulting. The way you fix an esophageal perforation is an esophageal stent. So if you think about the esophagus, it's perfed, there's a hole, then you need a stent to kind of go into the esophagus and close it up. So cardiothoracic surgery was consulted for the stent. All right. So we're going to talk about 3 different things here today. We're going to talk about pleural effusions. We're going to talk about pneumothorax, and we're going to talk about diabetic ketoacidosis. So pneumothorax, what is pneumothorax? It's intrapleural pressure, and that's more than the outward ambient atmospheric air. So in the lungs, if you can see here that there are normally 2 layers. There's what we call a visceral layer, which is right around the lungs, and then there's a parietal, which is on the outside. So the outer pleural layer is called the parietal, and the visceral layer is what's right attached to the lung. If this is the lung, this is the visceral pleura. And then on the outside is the parietal. So when air accumulates, that's what we call a pneumothorax, or air in the thorax, air in the lungs. Now, don't forget, the lungs are always a closed system. It's a closed system. As you can see here, there's ribs around it to make it a closed system. And basically what happens is when you take in a deep breath, you expect everything always moves from high to low. So as you take in a deep breath, you get more negative intrathoracic pressure. And this pressure allows air to come in because everything always moves from high to low. So you expect your the barometric pressure to be higher than the barometric or atmospheric pressure to be higher than your intrathoracic pressure. And this would allow air to move out to in. So out to in, you need to form a negative, you need to take in a deep breath, and that forms negative pressures in your chest. So air can move from out to in, because every gradient's always high to low. So anything will move from like high to low. Now, what happens in a pneumothorax is that disrupts this barrier. So if you get air in your lung, then you try to take in a deep breath, but you're not going to generate this negative pressure that you need to move air from outside to in. And because of this, the lungs don't get aerated. And that's when you see problems in oxygenation, you see desaturations, and you see patients becoming really sick from this. So yeah, so like we said, normally intrapleural pressure is normally negative. It's less than atmospheric for the air to move from outside to inside. So air enters the pleural space. So in pneumothorax, or air in the lungs, air enters the pleural space from outside the chest or from the lung itself. It could be a pleural perforation, meaning you can get trauma directly in. And when that also happens, the lung kind of decreases on itself. So if this is a normal expanded lung, you can see here in this pneumothorax, there's air all around that poor little lung, and that poor little lung is getting shriveled. So the volume of air decreases and pushes that lung. So all this air has come in and is pushing that poor little lung. And over time, what happens is that can cause tension pneumo. So if you see here, air is coming in and into this side, and let's say that there's a pneumothorax on this side, air keeps coming in to this side and it's starting to push on the left side. So there's a ton of blue, meaning there's a ton of air, and on the blue side, and it's pushing to the left. Now it's pushing to the left on the pink. Now this has implications in terms of hemodynamics or the heart, because everything is supposed to be maintained at a normal balance. If you're pushing everything to one side, then you're going to become hypotensive and start dropping your blood pressure, and you're going to start seeing problems with their hemodynamics. So they're going to start desatting, they're going to start having big distended neck veins, and you're going to feel the air when you touch their chest. Meaning if you touch them, it's like what we call Rice Krispies kind of sign. You see that in 2 different things. One thing is subcutaneous emphysema, which we'll get into later, but you do see it in this too. So if you do get a tension pneumo, is what we call it, tension, because it's pulling a lot of tension on one side, tension is causing it to move to the other. And the way you treat this emergently is a 14 gauge needle. You just kind of poke. So you find the second rib space, you go to the mid-clavicular line, and then you take a needle and then you poke. You try to decompress all of that air. So you try to break this tension and decompress it. So all the air will be released. So I've actually done this a couple times overnight. It's crazy. You have the needle, and then you hope you find the spot, and then you poke, and then you can hear the gush of air, and then almost immediately you'll see on the saturations and on the monitor, you'll see their blood pressure getting back to normal. You'll see their saturation starting to pick up. But immediately after that's open, you need a chest tube to be placed. Cardiothoracic surgery does that as well. Okay, so this patient, so this is what we call, this is not a tension pneumo. This is just a simple pneumothorax, and this here is a tension pneumo. So all this black, you see no lung markings. Lung markings are here with all the vessels. Lung markings are here with the vessels. On this whole right side is all black. All of this is air, and that's pushing all the mediastinum to the right, to the left side. You can see here is the airway, and that's the heart, and it's all being pushed over because of all of this air. So in this patient, the treatment emergently would be get a needle, a 14 gauge, and then poke, and then put a chest tube. Some patients like this, you can get away with just this side, you can get away with just putting them on oxygen. You put them on 100% FiO2, and this helps for reabsorption of the air. So if you put somebody on 100%, essentially the air that we breathe has 21% FiO2. So if you put them on 100% FiO2, you help the oxygen in their lungs to go back into their bloodstream by breathing in and out. Okay, so this is different types of pneumothorax, kind of like I was telling you about earlier. So there's the primary spontaneous pneumothorax, and then there's the secondary spontaneous pneumothorax. So the primary spontaneous pneumothorax, what we call primary versus secondary, is does somebody have any underlying lung diseases? Secondary would mean somebody has some type of underlying lung disease like COPD or chronic obstructive pulmonary disorder, cystic fibrosis, any type of lung cancer, any infection, any cystic lung diseases, just architectural lung problems that they were born with. So this makes for their lungs to be different than a normal person. If somebody has COPD, I'll show you an example. Yeah, so if somebody has COPD like this, then they already have these big dilated bullae is what we call it. Their air sacs are already so big. So if that person were to get this person were to get a spontaneous pneumothorax, or just essentially get a bunch of air in their lungs, they would be defined as secondary pneumothorax compared to a primary in somebody who does not have this lung architecture because they don't have COPD. Now you can see here that this is not a pneumothorax, even though it kind of looks like it. And the reason is because this has some lung architecture inside of it. You see that white, this is all vessels within it. So this is not a pneumothorax. This is just bullae. And here, this is all lung. You see all this white here too. So this is also just blebs. It's just emphysema or COPD. So going back to the definitions, this is, if this person were to get a pneumothorax, it would be secondary, not primary. So in our guy, our 25-year-old, he did not have any underlying lung disease. We asked him. He was a smoker, but he never had the definition of COPD. He just had diabetes. So he had a primary spontaneous. Now, spontaneous means it happens spontaneously. You wake up one day, you feel short of breath, and you have a pneumothorax. If it happened iatrogenic, meaning somebody was trying to place a line and they punctured the lung, then that would be iatrogenic. If the patient was on mechanical ventilation, like a life support ventilator, and then he popped the cyst, he popped a bleb, he got air in his lungs, then that would be iatrogenic. Traumatic, we all know what traumatic means. Maybe they were in a motor vehicle accident and something just went into their lungs, or went through their ribs into their lungs, punctured their lung. That would be traumatic. So those are important. Those are definitions that we do use when we are treating patients. And this kind of goes back to like what I was talking about. So primary and then secondary. Now treatment. So we kind of did go a little bit into this, but so if you do suspect a pneumothorax, then you do put them on supplemental 100% oxygen if they don't need like a chest tube right away. And then you look at different markers to see how to treat. If For example, their vitals. Their vitals are what you go off of, you look at. So their vitals being the respiratory rate. Are they very tachypnic, breathing like 40 times a minute, like because they just can't get in a deep breath. They can't generate that negative force to help air move from the outside to the inside. They just keep breathing like really quickly. SpO2, so their oxygen saturation, if that's decreasing, then that's a bad sign. Are they able to speak in full sentences? In order to speak, you need to generate a good amount of volume, a good amount of pressure. You need that gradient to speak even. So if they can't speak in full sentences, that's a really bad sign. I've had patients in front of me decompensate. They'll be talking like this, then they'll go like this. And it's happened with COVID patients. It's happened with patients that I've seen with pneumothorax or air in their lungs that needs emergent treatment. And then blood pressure. So heart and lungs are one. If the lungs are affected, more than likely the heart's affected. So that's also a bad sign. So then we spoke about the unstable patient. The unstable patient needs emergency needle decompression, like we said. An emergency needle, you do a 14 gauge, and then you go second rib, mid-clavicular, and then you feel, and then you insert. You have to make sure that you get imaging, like we said, chest X-ray. You can do a lung ultrasound as well. Lung ultrasound can help to see if the lungs are moving together or if they are not moving together. Like we were talking about earlier, there are two layers to the lungs. There's your parietal, which is your outside layer, and then there's your visceral, which is your inner layer, the layer that's touching the lung. If there's air between them, then the layers are not going to touch. And if they don't touch, you'll see that on ultrasound. Okay, so this is pretty much basically what we spoke about. You would need a chest tube, needle aspiration, just kind of depending on how bad the air in the lung is. And also, anytime you do put in, you do have air in the lungs, and you do either put somebody on oxygen or you do a chest tube, you always have to get serial imaging every day. Meaning you always have to get chest X-rays just to make sure it's not getting worse or not, and to hope it's getting better. So the point of treating a pneumothorax is you try to get the lung to re-expand. So here you can see the lung is small. It's really small. It's not going to be able to oxygenate or ventilate properly. So by moving or getting out all of that air, all of this purple, all this dark purple, if you get that out, then the lung will re-expand. That's the purpose of treating a pneumothorax, for the lung to expand so it can participate in gas exchange and oxygenation again. Okay, a little bit about DKA. So diabetic ketoacidosis is what we spoke about. It's very common among type 1 diabetes. There's a difference between type 1 and type 2. And it basically happens when there's not enough insulin in the body to meet the metabolic needs, like we spoke about. So insulin deficiency, it can happen because of many things. It can happen during stress. It can happen because of stress on the body from an infection. It can just happen because somebody forgot to take their insulin. It can happen because of trauma, UTI, pneumonia. So in this patient, when he came in with our 25-year-old, when he came in with shortness of breath and abdominal pain and feeling weak, nauseous, vomiting, DKA is one of the first things that goes through my mind. And any diabetic who comes in and they have any type of symptoms, I'm always thinking DKA. So DKA, you need a plasma glucose of 250. You can get an arterial pH. That's why we were talking about that patient with 7.2. And then you look at the bicarb and the BMP, the basic metabolic, and then you look at the ketones, if the patient has ketones or not. Ketones are important because ketones, like we said, that means that your body is not going through aerobic glycolysis. It is going through anaerobic glycolysis, and it's going through anaerobic glycolysis so much that the brain isn't getting its glucose that it needs. So then it's starting to break down muscle to get those ketones. So it's important to know that that's needed for DKA. And another thing is an anion gap. So anion gap is needed for diabetic ketoacidosis. You always look for the anion gap and you try to correct that through the insulin. So this is the protocol management for patients with DKA. It's a little complicated, but basically anybody who does come in DKA, we keep them in our ICU and we monitor them very closely. We do blood work on them every 1 to 2 hours. We check their finger stick glucose levels every hour. And then the blood work that we do is the basic metabolic panel to look at their potassium, to look at their glucose level if it's higher than what you can only get from a finger stick, The highest you can get from a finger stick is 250. So if their glucose is 905, like this guy, you try to check his glucose from a finger stick, it won't tell it to you. So you'll need a basic metabolic panel. So you get those every 2 hours. We treat with insulin drip, and the insulin drip, because the body is deficient in insulin, which is diabetes, but in DKA, they don't have any insulin. So you're giving them insulin exogenously through an insulin drip, and you're helping to treat the DKA. Other things that's really important to remember is that they are very, very, very dry. These patients have so much glucose, like this guy had 905, and glucose is, it dries you out. It sucks water. So then your body has like no hydration, and then you feel very dry, and you can see it in their lab markers. Like this patient had acute kidney injury from the DKA, very common. Okay, so our other thing we're going to talk about is pleural effusions. So this unfortunate gentleman perfed his esophagus, and because he perfed his esophagus, the esophageal contents leaked into his thorax and gave him a pleural effusion. So he had air in his lungs, he had fluid in his lungs, he had a perfed esophagus, and he had diabetic ketoacidosis. Very poor gentleman. But anyway, let's talk about pleural effusions. So we spoke about air in the lungs. Now, pleural effusions is fluid in the lungs. Fluid in the lungs can happen because, so our lungs are lined with vessels. Vessels are all over our body. And this mechanism is kind of similar to any type of extravasation of fluid wherever in the body. You have some type of pressures, like we spoke about in the lungs, that you kind of need to meet. Everything in our body is through gradients. So you have a hydrostatic pressure, which is here, you can see in your pleural space, you have the hydrostatic pressure. So that's the pressure within the vessel itself. And then you have your oncotic pressure, and this pressure is generated from protein. When those are off, when you have too much protein outside, or too little protein inside, or so you have something that's kind of pulling your hydrostatic pressure or your fluid pressure out of the pleural space, and that's the driving force for a pleural effusion. So there's two different major types of pleural effusions that we speak about. One is transudative and one is exudative. So pathophys behind transudative is you have a lot of hydrostatic pressure but decreased oncotic pressure. So you have a lot of hydrostatic pressure coming in from the sides and coming kind of into your vessels. And then your oncotic pressure is decreased, meaning in your visceral space, you have like low protein. So if you don't have a lot of oncotic pressure to kind of keep all that fluid that's being released out, then you're going to get a lot of fluid that kind of just stays in your thorax, because this is specifically speaking about pleural effusions. Yes, and you get an effusion. So exudative, you can get invasion of microbes if it's any type of bacteria, if it's any type of virus, if it's any type of inflammatory mediators, but something causes an initiation of inflammatory reaction. This then leads to vasodilation, or makes your vessels big, vasodilate, and then that increases your capillary permeability. So capillary permeability, it's just seepage. So you're just getting things seeping through. If this is your capillaries here, things are kind of just seeping in through the space and staying in the space around it. Just imagine things kind of going out and just staying in this space. That's what we call increased capillary permeability. You also get leak of the plasma proteins. And then if you leak your plasma proteins, meaning you're peeing it out, you're pooping it out, you're losing it one way or the other, then that's going to decrease your oncotic pressure. And that's kind of a lot of the basis for these effusions. You don't have the oncotic pressure around your vessels to hold all that fluid into your vessels. And it just kind of seeps out either through an inflammatory cascade or just through increased hydrostatic pressure. And that's what gives you the pleural effusion. So this patient right here has a pleural effusion. As you can see, the pleural effusion is on the left side. And the way you can tell that it's a pleural effusion is because there's no black down here. It just looks like it's just white. So we spoke about pleural effusions. It's just a collection of fluid in the pleural space. It's usually secondary to other diseases. So normally the pleural space contains 10 to 20 mLs of serous fluid. But this and pleural effusions, you'll just see a lot. So why does it matter? Because once again, it's pushing on your lungs. Your lung, if you see here, this is a fully normal expanded lung, but on your left side, there's just fluid here, and that's pushing this lung. So it's decreasing its space. So this part here is in not participating in gas exchange or ventilation, and it's decreasing this ability too as well. And also it's just very uncomfortable for the patient. So you'll hear a lot of patients who do have pleural effusion saying it's hard to breathe. So treatment for pleural effusion, you just take a needle and you just drain it. You can do it. Well, okay. It depends on what type of pleural effusion it is. So you need to go, well, yeah. So it depends on what type of pleural effusion it is. You need to go through the steps to figure out, is it transudative? Is it exudative? But a lot of the times what we as pulmonary do is we do take a sample of it to help us figure this out. So you take a needle, you go through the ribs, and then you take like a sample of it. And you can also drain all of it to kind of release the fluid. Now you can do this, but sometimes if you don't do it, you can give a diuretic or like a water pill, and that can help the patient pee it out if it's secondary to something that will respond to a water pill. So pleural fluid analysis, this is what we do to kind of figure out if it's transudative, is it exudative. We do a cell count, a cell differential. This can help us see if it's some type of predominance, like lymphocytic predominant, meaning it has a lot of lymphocytes in it, it has a lot of eosinophils in it, and that helps for cancer diagnosis. pH, protein, LDH, glucose, other types of different pleural fluid that we can do analyses. And these kind of help to tell us the differential of why this patient is getting fluid in their lungs, because it's not a common thing. And then you can just do gross appearance sometimes. Sometimes if you take a needle, you take out the fluid and it's yellow and pus, you're like, okay, this is straight empyema. Empyema is a very serious bacterial disease that needs a chest tube because it's going to cause it's just really bad environment for the lungs. So there's a criteria that we use to kind of see if this is exudate versus transudative, and it's called Light's criteria. So it's based off pleural fluid protein and serum protein, pleural fluid LDH and serum LDH. So usually if it's greater than 5 and then greater than 6, then it's exudate. And if you remember the pathophys behind both of these, the exudate has to do with some type of inflammatory cytokine pattern or reaction that does cause the decreased oncotic pressure. Transudate is just the hydrostatic, is just a difference between the hydrostatic and oncotic pressure. And because of that, there's not many causes for transudate. For exudate, you can see here that there is quite a few causes. You can see here, and some of these, the bacterial and viral ones, malignancies, all these have to do with different types of cytokine reactions that then cause this. And our gentleman, he had an esophageal rupture. So that's on the exudative side. This is kind of going through basically what we talked about with the pleural fluid analysis. Empyema, you can just look at it. You'll see it thick, yellow, smelling bad, and they'll have positive cultures. And all these other ones kind of can be determined by some type of pleural fluid analysis. So it's really important to get that pleural fluid one way or the other and then take it to the lab to analyze it. Treatment. This is important. So treatments, you always try to, if something is pushing on the lungs, you need to release it so the lung can re-expand, whether it's air, like we spoke about for pneumothorax, or it's fluid, like pleural effusions. So we said thoracentesis. Thoracentesis is just when you take a needle and then you take it out slowly. You can do up to 2 to 3, but we don't really recommend doing like 4, 5, or 6, because at that point it's like, you're just going to keep on sticking a needle into this patient, and you're going to cause risk of, you might hit the lung, or there's just a lot of risks involved in it. So if somebody needs pleural fluid drainage more than 2-3 times or more than 2-3 thoracentesis, then we can place a tunneled catheter. So it's called indwelling pleural catheter. This is a tunnel catheter, and it's just placed in the patient, and they can drain themselves. Other things you can do is pleurodesis, a chemical versus mechanical, and that's when you open up the lungs, and you do this through surgery. So you can do it through a VATS, or video assisted thoracoscopic surgery. You take like a small catheter, and you go in laparoscopically into the 2 layers of the lungs where the fluid is, and then you inject this slurry versus powderage. It's just a type of chemical, and what it does is it induces inflammation, and the inflammation between the visceral and parietal pleura, or the 2 different lung two different lung layers, the inflammation will cause it to close up on itself. So if it closes up on itself, then no fluid will get in between. That's the thought behind that. You can do a chest tube again. It depends on what the pleural effusion's from. Is it from hemothorax, or if it's from something that's very like empyema, then that needs chest tubes. You can do a sclerosing agent, talc, or some type of antibiotic, which is kind of similar to the way we spoke about taking a tube and going in and kind of injecting something between the visceral and parietal pleural. Okay, so this here is a chest x-ray. I just wanted to show you guys what a normal chest x-ray is, because we've been looking so much at ones with air, ones with fluid in it. Basically, when you are looking at a chest x-ray, you look at, so this is kind of a mnemonic that I like A, B, C, D, E. So A is the assessment quality. So you look at the quality, you try to see anywhere from 9 to 10 ribs on inspiration. So you count here, and then you can count 1, 2, 3, 4. You kind of count between the ribs, and then a good chest x-ray on inspiration should have about 9 to 10 ribs. Then you look at the airway. So this here is the airway, and you can clearly see it. It does not look like there's a tube in the airway. That's important to look at as well. So you can tell if a patient's intubated or not. And then the quality of the picture, or assessment quality. So if you can see the spine here, if you see these spinal processes, or the spinal processes, or the vertebrae we call it, which you can see here, but not as clearly. So it's probably not the best chest x-ray, but you can see it. The clearer you can see the spine, the better of a film you know it is. Because people can trick you. People will say, oh, they'll put 2 chest x-rays side to side, and they'll be like, oh, look at these are drastically different. But one might just not have been shot as well, meaning the lighting could have been off. It could have been too dim. Maybe you see it over brightened in one chest x-ray, under brightened in another. So the way you kind of go about is like, look at the spinal processes, you count the number of ribs, and you look at the airway. So that's the A. That's what I call the A. The B is the bone. So you look at the ribs and you try to see if you can see any fractures, and you look at symmetry. So if here you see the 2 clavicles on both sides, and they look like they're pretty straight. If one clavicle is like this one was more like this, then you would be like, that's a rotated film. And you can't really read too much off a rotated film. You need the patient to be straight and for them to shoot from the middle. But yeah, so it looks like good bones, no fractures on that. C is cardiac. So here, cardiac, you look at your heart, and usually your heart should be, we say, less than 50% of the hemithorax. So here the heart definitely looks like it's less than 50%. More of it looks like it's the diaphragm, which is a good thing. If it's more than 50%, like if this heart went all the way to here, then we think like, oh, this patient has like cardiomegaly, or just a big heart. Then D is the diaphragm. So that's what sits here. In COPD patients, you'll see the diaphragm really low. And you'll see it very straight in patients with COPD. So here you can see a little bit high on the right, which is normal. A lot of people have a slightly high right diaphragm, but it's not crazy high to make you think like there's hemiparalysis or hemidiaphragm on this patient. But D is the diaphragm. So you do look at the diaphragm. Sometimes some people will have a paralyzed diaphragm, meaning the right side will be much higher than the left. You'll see it like that. Or the left side will be much higher than the right. This can happen from cardiac surgeries, or it can happen from any type of surgery done in the cervical area. If someone has some type of neurospine disease, or they go for neurosurgery for one cause or the other. So D is your diaphragm. E is effusion. So we already spoke about the effusions. Here, you see clear angles, acute angles, or we call these acostophrenic angles. They are acute. They are sharp. There's no blunting of the angles, meaning that there's no fluid or effusions. That's the E part. Yeah, so that's pretty much like what I look at, A, B, C, D, E. And then sometimes I'll also go through F. F is like foreign objects. So if somebody has a pacemaker, an AICD, any foreign objects on the chest x-ray, I use that as my F. So when I'm teaching my residents, or I'm teaching my medical students, that's what I tell them to kind of go through a chest x-ray and look at. All right. I know it's getting really late, but I just have one more case for you. So we have an 11-year-old female who comes in with shortness of breath, fevers, body aches, rash all over her body, tongue with redness. She has a history of thyroid disorder. Her parents tested positive for COVID-19. Patient was negative. And just for the sake of time, I'm just going to go through this one. So you have 11-year-old who has all these weird symptoms: body aches, rash, tongue with redness. She has a history of thyroid disorder. Her parents tested positive, but she tested negative. What could it be? Well, in this patient, unfortunately, even though she is only 11, she got COVID. It's called multi-system inflammatory syndrome in children, MISC. And this is kind of based off a real case. On pulmonary, we do get consulted on pediatric ICU COVID patients. And we get consulted as adult pulmonary to help assist with children's pulmonary at the PICU, pediatric intensive care unit. So in children, COVID-19 is usually mild. However, in rare cases, children can be severely affected, and clinical manifestations may differ from adults. So it's super interesting to note is this patient has tongue with redness, rash all over her body. That's not common in the adult population. So in April 2020, reports from United Kingdom documented presentation in children similar to Kawasaki disease or toxic shock syndrome. So with the tongue, the rash, the fevers, the body aches, that's really common in Kawasaki or toxic shock syndrome. So it's a little different to see that when we as in the ICU doctors were seeing that in children, we're like, wait, this is really weird, especially because children test negative. So it's different. We're going to talk about the children testing negative in just like a couple slides. Management of children with MISC or multi-system inflammatory syndrome in children depends in part on the clinical presentation. And so you're basically just kind of treating their symptoms. So if they come in shock, meaning they have low blood pressure, they're in multi-system organ dysfunction, you're treating it one by one. You're treating their shock, you're treating their fevers, you're treating whatever syndrome it looks like. So this chart is really small, but basically they're presenting symptoms as we kind of spoke about with this patient: sore throat, myalgia, swollen hands and feet, lymphadenopathy, red eyes, fevers. That's very different than the adult population. The clinical findings, they would have shock. They have a lot of heart problems. Adults do get heart problems, but not in the same context, or not in the same, not as much as kids in the initial presentation. Adults get it, but after. They get serositis, meaning they get pleural effusions, just like we spoke about. They get effusions in their heart. They get abnormal lab tests and values. And the way that this happens, once again, just going through COVID in general, COVID is a virus. It goes through our respiratory system, whether it's your ears, or not your ears, sorry, your eyes, your nose, or your mouth. So these virus particles kind of enter in through, and then it goes directly into your trachea, into your lungs. And then when it goes into your lungs, it damages these small alveoli or gas exchange areas. It damages them by killing the type 1 and type 2 cells. And not only does it damage in kids, because they have their immune systems are building. They're not yet fully immune. Their immune system still hasn't built. They haven't gotten all the vaccines they need. They're still in the growing phases. So because of that, they get more of a robust immune response to this. So COVID goes into the lungs, like we said, it destroys all the type 2 alveolar cells. And then when the body realizes that it's getting attacked, the body starts sending cytokines. It starts sending a bunch of cytokines throughout the body. Now, this is more targeted to the lungs in adults, and it's more targeted to somewhat the heart in adults, but it is a systemic disease, but more we see the lung findings in adults. In kids, it's robust. It goes to the skin, it goes to the brain, it goes to the heart, it goes to the lungs. And it has to do with the fact that their immune systems are still developing. So pathophysiology, how this happens. Like we spoke about, it's immune dysregulation. Well, first of all, this is not well understood. It's on the rarer side for children to get super, super sick, thank God, but it does happen. So it has been suggested that syndrome results from abnormal immune response to the virus, similar to these vasculitic syndromes like Kawasaki's or macrophage activation syndrome and cytokine release syndrome. And this has to do with, it's just the body getting this virus and the body kind of attacking itself in the best way it can. But it's hard for somebody who doesn't have a proper immune system to attack this when their immune system isn't even fully developed. So like we said, SARS-CoV-2 virus, many affected children have negative PCR testing, but have positive serology. And this supports kind of the hypotheses that MISC or Miss C, is related to immune dysregulation occurring after infection has passed. However, some children do have positive PCR testing. So if you do remember in this patient specifically, she tested negative for the PCR, but the patient tested negative, but her parents tested positive. So in this specific patient, later on, she ended up testing positive for the serology. This was her CT scan, which is extremely unfortunate. So you can see here that there's a bunch of air. So she has air in her lungs. She has a bunch of ground glass opacities, or what we call just stuff in her lungs, all throughout both sides. There's air surrounding her heart. There's air surrounding her subcutaneous tissues. That's all around. So a very unfortunate situation in this consult that we did get. Now, this is a chest X-ray kind of depicting what SARS-CoV-2 does in a chest X-ray form. So you guys now know what normal is. So you can tell that this is completely abnormal. There's not much aeration going on. Aeration would mean that it's more black. Here you see scattered areas of just white. The white is just ground glass. It's just cells that are just not being broken up. It's just cells that are just taking over the gas sacs or the alveoli and damaging parts of the lungs. So this is SARS-CoV-2. This is SARS-CoV-2. It doesn't always have to present like this. It can sometimes present like this. So basically, like we spoke about, it is a disease of the whole body. It does specifically attack the lungs and the heart because of it needs the ACE2 receptor to kind of start, but it does affect the whole body. And this is kind of how. So from head to toe, it affects almost every organ. And these are certain types of labs that we do get to test patients who do get COVID, to check how they're doing, how their labs are doing, how their inflammation is reacting to treatments that we are able to put them on. Our main goal when we do treat these patients is to stop the inflammation. We try to stop that cascade. We try to stop the cascade that happens here when the body realizes that a virus is attacking the body. The body then sends all these cytokines. So we try to stop that immune response by steroids when we can, early enough. But yeah, so wear a mask, and I hope that this was very informative to all of you. I will take any questions you guys have now. I love this quote. I just think it's great. A journey of 1,000 miles begins with a single step. It's so easy sometimes to kind of forget that the need for doctors is huge. The need for doctors is great. And all of you guys who are on the pre-med track, who are trying to become doctors, like, I applaud you. I think that what you guys are doing is great, and keep doing it. It's very easy to kind of forget, get demotivated, be like, oh my gosh, this is so hard. I was there. Sometimes I still am. But you got to just power through. It's always one small step, whether it's doing one question right now and then not doing any for the rest of the night, or just kind of maybe today was your learning session and you're good for the day. So it's just kind of just remembering little steps go a long way. Sometimes I still have to remind myself of that too. So thank you everyone for attending. This is my contact information. You can follow me on Instagram. I post about my day, different cases that I see that I think are interesting. Different cases that I see that I think are interesting. I do post stories about. This is my website. I haven't really updated in a long time, but I do speak a little bit about my fellowship. And that's my email address if you guys want to reach me. Okay, I'm going to open up the chat now. What is the difference between cardiomegaly and cardiomyopathy? Cardiomyopathy can cause cardiomegaly. Cardiomegaly is just a finding. It just means big heart. It doesn't tell you what caused the cardiomegaly. It could be heart failure due to cardiomyopathy. It could be heart failure due to tachycardia or high heart rate, causing the heart to just become bigger. So cardiomegaly is just a finding. Cardiomyopathy is the reason for the finding. Are any of the white spots on the scans mucus phlegm buildup? It could be, but it's non-specific. So when you see white spots, on a lung like this, it's what we call ground glass opacities. ground glass opacities, very non-specific finding. Ground glass opacities can be one of 5 things. It can be cells, it can be protein, it can be blood, it can be fluid, or it can be cells, protein, blood, fluid, or it can be virus. So we don't know what one of these 5 things are, but that's what we say white spots, ground glass opacities, fluid from heart failure. It can be cells from ARDS or any type of pneumonia. It can be blood from maybe they're bleeding into their lungs. It can be protein from protein alveolar proteinosis. That's a very rare diagnosis, but ground glass opacity is very non-specific. So yeah, it could be mucus phlegm. How has COVID-19 affected your work life? COVID-19 has affected my work life and almost everything I do. Since I am Palm Crit, I now carry a pulse ox every single place I go, whether it's to the grocery store or not. But no, for real, COVID-19 has affected a lot. It's one of our top differentials. Anytime someone comes in, it has affected the way we dress, the way we what we wear. Normally I'm in a scrub hat. I have 2 masks on. I have a face shield because I'm pulmonary critical care. So we do see respiratory problems. We see COVID. We see COVID in the ICU. We see COVID as pulmonary consults. It definitely, so it's affected our work life and almost everything. I would say last year, COVID had a huge play in the mental aspect, mental, emotional, because you're seeing all these patients that are dying and they're not able to talk to their family. So you're sometimes the only person they talk to before they pass. So it had a huge play, I would say, a lot on like mental, emotional, physical, fatigue. It's gotten better though with the vaccines. Thank God it's gotten a lot better with the vaccines, especially more and more people getting vaccinated. What does a typical workday look like? So a typical workday, because I do ICU, but I also do pulmonary consults. It really depends on what rotation I'm on of the month. So for example, last month in January, I was in the ICU. So when I'm in the ICU, my day starts at 6 a.m. in the hospital. So it actually starts at 5 a.m. when I wake up. And then I'm in the hospital from 6 to 6 sometimes if I'm on call, which is every other day. So 12-hour days, but 12-hour usually become 14-hour. Or if I'm not on call, then I can leave at 4. So 6 a.m. to 4 if I'm not on call. And that's in the ICU. Then if I'm on pulmonary consults like this month, my day starts at 7 a.m. when I wake up, and then I have to be at the hospital by 8. And I have residents, they present to me the new patients that we have for pulmonary consults. We go over a plan, then we go around, then we talk to the attending about it. We take new consults throughout the day, and then I teach the residents. So it really depends on what rotation I'm on for the typical workday. Why stop the immune response if it is supposed to be fighting the disease? That's a great question. Why stop the immune response if it was fighting the disease? So we didn't even know how to treat COVID in the beginning. Like we really had zero idea. And to be honest, we probably still don't know. You stop the immune response because it becomes so great. It becomes too much that it takes over. And that's a problem. If the immune response is so much that it takes over, then your body is starting to fight itself. And that's why we see I guess now they're finding autoimmune disorders from COVID. So it's like COVID is causing its own autoimmune disorders. And autoimmune disorder is auto, so it's yourself. Immune is your immune system. When your own immune system is attacking itself. And that's essentially what COVID causes. So you try to mediate the immune response by immunomodulators. Like when we were using interleukin-6, we were giving that medication to patients. It was not helping at all. The only thing that we found that was helping was steroids. If you had a chance to start over, would you still choose to go into the medical field and specifically into your specialty? I cannot see myself doing anything else than what I'm doing now at all. I love what I do. It's when I'm in the ICU, it's very fast paced. It's go, go, go. It's one thing after the other. It's, oh my God, this patient has air in their lungs. Oh my God, this patient has fluid in their lungs. We need to stick a needle here, stick a needle there. This patient is crashing. We need to tube this patient, but I love it. It's just so great. And you're always so excited. There's always something more to do. So yeah, I would definitely 100% choose this specialty. Have you seen anyone get the virus more than once? Yeah, unfortunately, I have actually seen the patient get the virus more than once. I've seen maybe like 4 or 5 patients get it again. Not as severe. 2 I saw get it severe the second time, but 3 just got it, but they were just very mild. And to be honest, one of them, we just didn't even know if they just never tested negative. Okay, was that all the questions?
Yeah. Thank you so much for answering all of our questions and for an awesome presentation. We enjoyed all of the visuals you provided, and thank you so much for presenting again.
Yeah, of course. It was great presenting.
Thank you. Everyone, make sure you check out her socials. Her Instagram is NeenaCMG. Additionally, thank you all so much for attending. The Google form has now been posted and it will remain open for the next 30 minutes, so please make sure you fill it out. Thank you so much. We loved it and it was super interesting, especially with COVID-19 going on.
Okay, great, guys.